Good evening, everyone. Welcome to the GDIA August edition of the webinar series. My name is Dr. Setare Lavasani, and we'll be talking about applications of CBCT for dental implants. To get your CE at the end of this session, please make sure to remain active during the session, and at the end, a pop-up window will appear in your screens for evaluation, and you can receive your CE credits. For tonight's topics, we'll be going over the importance of pattern recognition when we're looking at our CBCTs or 2D images. The important thing is to first and foremost rule out pathology. But the question that comes to mind is that do we even know how malignant pathologies look like? Are we even equipped enough to evaluate pathologic conditions? So one of the things that we will focus is that. Then we will talk about maxillary and mandibular anatomical considerations and variations from normal in our CBCT scans. And then we will go over maxillary sinus pathologies. Maxillary implants, we have a lot of cases that we will also cover the sinuses. So there are different types of inflammatory, viral, and so forth, different types of pathologies. We'll go over those. What's the radiographic appearance of those problems? And then we'll talk about CBCT limitations. What are the artifacts that are associated with our scans? And also we'll touch on the subject of the importance of interprofessional communication. So we have three cases in the beginning that we will discuss to kind of emphasize the role of pattern recognition in our daily practice. This was a 50-year-old female that came to our practice. She was a 15-year cancer survivor and breast cancer survivor, and she was on bisphosphonates for the past 10 years. If you look at the area of 29 and 30, they are edentulous, so she wanted to see what's her options to place an implant possibly in that area. Looking at her panoramic image, you can see just adjacent to that area on the mesial side, we have number 28, number 27, and a little bit of number 26 that are showing areas of irregular PDL widening. You can see that there is a kind of destruction of lamina dura. We can see it better in our periapical image here with the arrows, and kind of the PDL widening goes around and goes in between the teeth with no exact explanation. So when we saw this one, I asked for our students to refer her to our CBCT clinic, because this is not a pattern of normal PDL widening or loss of lamina dura that we usually see. Usually we have inflammatory products in our inflammatory problems coming out of the apical foramen, and you see there is destruction of lamina dura. Okay, we know inflammatory products did that. And if we have lateral canals, similarly we'll have loss of lamina dura and PDL widening. But this fashion of loss of lamina dura not in the apical and in such an irregular manner is something that should bring up a kind of an alarm to do further evaluation. So this is a panoramic reconstruction of the case. This is the axial view. As you can see, there is extensive areas of cortical bone loss in the area of anterior mandible. You can also see on the lingual side, we have the similar pattern of bone loss, which is called moth-eaten areas of bone loss. If you know how those radiographic signs are, moth-eaten or permeative changes, this is exactly what is that. And also our cross-sectional imaging is confirming there is interruption of the cortex, and also there is enlargement of lamina dura. The blue arrow is showing us how a normal lingual cortex would be looking like. So in reality, the eyes can't see what the brain doesn't know, and I can't emphasize that enough, that if we don't know the appearance of different diseases, we can't diagnose them radiographically. So this was a 3D volume rendering of the case. As you can see, there is confirmation of extensive bone loss in the anterior mandible. So we sent her case to our biopsy service, and the biopsy came back, and unfortunately she had areas of metastatic breast carcinoma. So what we saw was areas of invasive carcinoma that has kind of spread to her mandible. So definitely we have to be sure to know the patterns. So one of the patterns we learned in this case is irregular PDL widening that you don't have any explanation for. So let's take a look at our second case here. Take a look at the panoramic image here for a few seconds. As you can see, we can totally differentiate and appreciate the areas of the boundaries of the right maxillary sinus. Here we see the floor of the maxillary sinus, and then when we come this side, we see, yes, the medial aspect of the floor of maxillary sinus. And then when we're going a little bit more backwards, we see that there's kind of destruction of the floor of the sinus. And when we look closer in this CBCT and even in the panoramic, we see there is loss of interdental bone. Also on the last part of our maxilla, what do we have in the last part of maxilla? That's going to be maxillary tuberosity, right? So on the left side, we've even lost the area of maxillary tuberosity. So there's so much bone loss and so much destruction, and these teeth appear to be kind of floating in the sea or floating in the sky. They call them floating teeth appearance. So again, floating tooth appearance is not a great sign. But before we always think about it as not a great sign, let's think about some people that come to us and they have generalized perio. So people who have generalized periodontal disease, all of their teeth are kind of floating in the floating teeth. But when you have a localized area of a floating tooth appearance, that's the time that we have to kind of increase our alarm and do a more thorough soft tissue evaluation, or send it to get a biopsy or further imaging, as we see here in sagittal view of CBCT, to see what's happening. So this case is a case of gingival carcinoma. So gingival carcinoma is a type of squamous cell carcinoma that arises in the gingiva and can go out all the way up, destroy all the area of the sinus, can go to the sinus, and can be really have a high mortality rate. So a simple pano, a simple PA or something can have so much vital information in it for us. So let's take a look at this other case here. Let me show you these two crop panoramic images here. One of the images is from 2014, and this is a young 17-year-old patient. As you can see, he also has the braces on. So take a look at the panel for 2014 and the panel of 2015. Let's look at the area of number 17 a little bit. The crop panel from 2014, at that time he had no complaints. He was doing his treatment, and that's the panel, kind of like the baseline panel they had from him. In March of 2015, he goes to the doctor and complains of numbness and a little bit kind of intermittent numbness and pain in the area of his left mandible. So they take this panoramic image, and really nothing special that you say would come to eyes, nothing comes to their mind. So they ask him to come back in April. So in a matter of 1 month, look at the changes that you see in the area of number 17. How would you describe these changes? You would say, yes, the patient has some area of bone destruction, but this pattern of bone destruction, which is called moth-eaten areas of bone destruction, which we saw in the first cancer case, are usually not a good sign and usually associated with malignant lesions. And I also put this here for you so that you can have a better visual of what a permeative tooth destruction, bone destruction would look like. So basically, like moth has eaten it, or permeative. This is what we mean when we talk about moth-eaten areas. So long story short, the patient got to biopsy, and they biopsied, and it was intraosseous squamous cell carcinoma, because we can have different types of squamous cell carcinoma, and that was in the bone, originating in the bone, carcinoma arising in the bone, and this was the kind of the management that they have to do. So as you can see, it's a lot of destruction, and these cases are the cases of life and death. But when he came and his panel showed kind of a little bit normal, a little bit abnormal, it's good that they took it further, and they took further steps to be able to at least save his life. So moving on to our other case here. Let's take a look at these coronal, sagittal, and axial views here. Look at the sagittal here, and then the coronal and axial view here. I give you a few seconds. So looking at these images, you may think there may be some problem, or there may not be a problem. This was actually a case that was seen in San Antonio, Texas by some of our colleagues, that they were looking at implant planning for maxilla and mandible. As you can see, maxilla and mandible are in the field of view, and when the image was being evaluated, it was seen that there is a blob of soft tissue originating from floor of the mouth. So as you can see, when you follow it on the axial view, you see that kind of a mass is present here. And look at the hyoid bone, guys. Also, hyoid bone has been resorbed. So this is a destructive lesion that's also resorbed the area of hyoid bone. So really, in reality, many people take a cone beam CT for implant and they say, yeah, we are looking only at the area of implant, but there are so many small details that are in that volume that the eyes of the evaluator may not be trained to catch it or trained to be able to diagnose it. So that's a huge liability, and the person who's responsible for that scan from A to Z of that scan, whatever that's covered in that scan, is the practitioner who has ordered the CBCT and has acquired it. So really, it's my responsibility here, I feel, to kind of show you this important article that was published in the O journal in 2008, and kind of talks about performing and interpreting the diagnostic imaging for cone beam. In the section of practitioners' responsibilities, I had it here for you larger, it talks about two important things. First one is that the dentist that uses the CBCT should be held to the same standards as a board certified oral radiologist for interpretation, and that's really a very not a good position for a person that's not a radiologist to be held to that standard, because they haven't been gone through the training, so that they don't have the luxury of being able to diagnose. So that's a bad position to be. And also they say clearly that as a pathology report that has to be accompanying a biopsy, any CBCT scan must be accompanied by an imaging report. So God forbid, if something happens, if something is missed and the CBCT is not being read by a radiologist, this is the article that they will ask a legal expert or a consultant to come and show this to the jury, and they will hold us accountable. So let's make sure that if we take CBCTs, definitely send them to a radiology service to be read, because there are so many things that we don't know and we may miss them. And definitely different examples of malpractice, failure to refer to specialists, all of them are kind of have been discussed before. So let's move on to our anatomical structures and implant complications. So when we want to talk about implant complications and preventing them, there are basically three categories that we can talk about, and there are two main categories of anatomy related matters and treatment plan related matters that have to do with imaging, and imaging can help us prevent those injuries and problems. So we can prevent nerve injury, bleeding, or minimize them, prevent perforation of the cortices and sinuses, and kind of know the width, orientation, length of our edentulous alveolar ridge, and kind of go from there and prevent all of those problems that may have to do with the failure or unsuccess of our implant procedure. So let's get started with our cross-sectional imaging. You know, we always hear cross-sectional imaging is needed for implant planning. For a long time, we've been trying to have a third dimensional view of the anatomical structures that we want to use implants on. And as you can see from 1936, that we had the linear tomography, we had not the best resolution, we had poor resolution, and computers weren't that strong. And then in 1971, when we had the medical CT, high dose, not such a good resolution. But as we kind of improved upon our technologies and computer systems and reconstruction systems, we introduced the CBCT. So now we really have a nice cross-sectional imaging tool in our arsenal for implant planning. And two of the important that I will pass from them very fast. Two of the important position statements on use of implant planning with CBCT have been published in 2000 and then in 2012, that they all ask the practitioners to use some type of cross-sectional imaging. So I wanted to tell you what is cross-sectional imaging. That's kind of how then you can get cross-sections and see the third dimension. So what are the structures in maxilla that we want to say? So maxillary anatomical considerations for looking at our implant cases. One thing that we know for sure is that as we lose teeth, there's a process of atrophy and remodeling of our bone. So we will lose areas of alveolar bone. So as you can see in these coronal views of CBCT, you see that the floor of the sinus keeps coming down, and also the coronal part of the bone height is being reduced. So we will lose bone in two aspects. One, from up to down, the sinus wants to come down, kind of pneumatization, that's the process. And also we'll have remodeling of the alveolar ridge, that we will have a reduction in our bone height. So pneumatization of maxillary sinus is basically an inferior displacement of the floor of maxillary sinus. As you can see it here, you see that there's a kind of a radiolucent area, and this is the floor of the sinus, how inferior displaced it's looking. So first thing, we will look at the shape and character of our edentulous alveolar ridge. And other thing we can see from 3D imaging is the orientation of the ridge. Look at the right area of the maxilla there. So we have, like, let's say number 3, 4 area that's edentulous. In the panoramic image, we may not be able to know what's the direction of this ridge. Is it buccal? Is it lingual? But when we have the cross-sectional imaging, in addition to having the measurements of how long and what's the height and what's the width, we can also see the direction of the ridge. So basically in this example, our ridge is kind of coming towards the buccal aspect. So knowing that information prevents us to have many problems. So take a look at one implant here. What do you think is the problem with this implant right here? Because we have enough area of ridge height, but the implant is going straight in. So in this time, the patient or the implant has a wrong orientation. If they had a cross-sectional imaging, they knew that the ridge is not going straight up. The ridge is kind of going in a not straight way, in a different direction. It's kind of coming buccolingually more. So in another example, we'll see that the implant has a good orientation, but as you see, there is interruption of the buccal cortical plate here. So the problem here was that they didn't properly measure, or they didn't even use cross-sectional imaging to measure the buccolingual width that was available. So they used an implant that's larger than it's supposed to be. And also sometimes we can have different implants that are so close to the buccal border or to the lingual border, and due to the presence of beam hardening, sometimes when the bone is so thin, it's really hard to say if we have any bone, if we have any at all in this area. So not always we are able to see how much bone is present. So that's the consult that I get. So buccal plate, unless it's thicker in the area that is so thin, you see that we have this artifact that's called beam hardening, and we'll talk about it in the artifacts of CBCT, kind of limits our diagnostic ability. So need for a sinus lift. Many times we have ridges that are really atrophied, so we can definitely measure those ridges and have a pre-op evaluation, and they want to do a sinus lift. As you can see, they will elevate the Schneiderian membrane here with a blunt instrument, and then they enter the bone preservation, or bone chips as they call it, some people, and so forth. So we see the post-op CBCT, it can tell us exactly how much bone we have now available. So the good thing about CBCT measurements is that they are kind of one-on-one, meaning like there's no elongation or no foreshortening as what we see with or 2D images, like a PA that is kind of technique sensitive. So you may see 12 millimeters, but in actuality you may have 11 millimeters or 10 millimeters. So there's no elongation or foreshortening or distortion of measurements. So sometimes we have areas that are edentulous, and also on a panel they really don't look like so much, we can't evaluate their deficiency, buccolingual deficiency. So here we can see in the area of right posterior, here we have, let's say, area of number 3, here this is 4, and then we have 5. So 3 and 5, and then we have on the other side. So let's focus on this one, on this area. Let's talk about how a normal contour of the buccal cortical plate should be. So usually you have to have something like this or something like this in the right side, but when we have long-standing edentulism, or when we lose our teeth in those areas, we'll have a lot of kind of bone resorption and bone remodeling on the buccal side. So with CBCT we are completely able to see how much bone we have lost, so how much bone width we have, and how we have to think about and different modalities that we have to think about to preserve and bring back our lost bone area. Similar things for buccal bone deficiencies that can be in aesthetic zone, they can be bilateral, they can be unilateral. In this case you see there is bilateral buccal bone deficiency, and if you look in the panel you see, yeah, the bone height is really good from here up to here, and even here the bone height has no problem, but look at the shape of the ridge, how thin it is. Here is 3.8, in the thinnest area we have 1.56. so you can see that from a 2D image there is no way that we can evaluate the deficiency that we have here, this buccal deficiency, and the shape of the ridge that is so very thin. So definitely helps us to have proper precautions and proper planning for our implant placement. So we also can evaluate the grafts when we have deficiencies. Sometimes we use block grafts to mitigate the situation, and then we have block grafts that are in place. These are called tenting screws. So after some time, after a few months, they come and take another CBCT to see how the graft has incorporated and integrated with the area of the edentulous area. So this would be an example of a nice integration. So you see there is no radiolucency or low density area between them. A little bit more, let's say apical, I see still there is a radiolucency. So maybe this graft still needs some time, because in here in the coronal portion it has integrated, but in the apical portion still there is some radiolucency. So definitely evaluation, post-op evaluation of block grafts is something that we can do. So the other thing you want to think about is the nasopalatal canal. We know that it's in the midline of the maxilla, so almost when it's up to 6 millimeters, it's within normal limits. When it has nice cortication, on this side you can see there is one nice cortication, and then when it gets larger and when it gets kind of irregular, it's time to send it for a biopsy, most probably nasopalatine duct cyst, but definitely needs to be ruled out and evaluated. And sometimes we have different variations of normal anatomy, like this one looks like the Mickey Mouse, but this one is normal. Sometimes the opening can have different shapes, it can have heart shape, Mickey Mouse shape, or different types, but as long as it's not that large, it should be fine. The other thing we want to talk about is evaluation of maxillary sinus. So maxillary sinus, first of all, we have to know what's normal. So what's the normal anatomy? What are the variations of normal? And then we'll cover some pathologies and opacifications of the maxillary sinus. And then we'll think about and talk about some benign and malignant conditions that can happen in our maxillary sinuses. So for any maxillary CBCT scan that you want to evaluate, it's really important to think about and always evaluate these three factors. First and foremost, if your scan is covering the area of osteomeatal complex, definitely look at the patency of osteomeatal unit. We will look at it at this moment right now. What is the osteomeatal unit? And then look at the sinus boundaries integrity. Make sure that there's no resorption, no enlargement, no no anything away from normal. That has to be a smooth boundary. There's nothing beyond that. And also look at the opacification. There are different types of sinus opacification. So sinus by itself is like a 6-hour, 8-hour lecture to know all the benign and malignant conditions that can happen in the sinus. But for our limited time, let's first look at the osteomeatal complex. So guys, let's look at the first image here. So as you can see, this is maxillary sinus. This area is open and the mucosa of the sinus drains here, which is called the middle meatus. So this is the inferior turbinate, this is the middle turbinate, and below the turbinates are the meatuses. So below middle turbinate is middle meatus, below inferior turbinate is inferior meatus. So this shaded kind of part of the maxillary sinus is called the osteomeatal complex. And before we go to this one, which is a coronal view of CBCT, let's look at the image in the middle. So the image in the middle is showing us that all of these mucosa producing cells in the sinus produce mucosa and kind of guide them to go up and out and drain into the nose from this area that's called the ostium. The ostium of the maxillary sinus is the area that all of these things come here, they go up here to hiatus semilunaris, and then they drain here. This small bone thing shape is called the uncinate process. Infundibulum, ethmoid bulla, middle meatus, they all make up what is called the osteomeatal complex. So any sinus that has this area open and the mucosa can flow, most probably is within normal and healthy in that regard. But whenever you see opacifications in this area, it's kind of the definition of a sinusitis. So let's get to work and see what information we have about radiopacities in maxillary sinus. So let's take a look at this well-defined dome-shaped mucosal thickening on the floor of the maxillary sinus. First question whenever you see a problem with maxillary sinus is to see if the lesion is from within the sinus or it's going into the sinus, meaning is it most probably non-odontogenic or maybe it's odontogenic and it's going to the sinus. So in this case, take a look at this dome-shaped area. What do you think? I say let's look at the floor of the maxillary sinus, right? So before you want to make a decision that this radiopacity is from within the sinus or outside, look at the floor of maxillary sinus. So we see that the floor of maxillary sinus is intact, it's not changed, it's not moved, no superiorly nor inferiorly. So this is the whatever entity it is on top of the maxillary sinus. So this entity is from within the maxillary sinus, so most likely non-odontogenic. Then take a look at this one. Take a look at this opacity in the maxillary sinus. Do you see that this is the floor of the maxillary sinus and it's been displaced superiorly? Yes, right? We all see that, and it's in association with the buccal root of this molar tooth here in the right, it's a right maxillary molar. So this by itself tells me that there's a problem here with this tooth that's kind of whatever infection that is, it's causing slow elevation of floor of the maxillary sinus. So this opacification that looks to be in the sinus, it's kind of being pushed into the sinus and it's not from within the sinus. So this one is a very common finding in maxillary sinus and it's called mucus retention pseudocyst. Mucus retention pseudocyst is a phenomenon when we have some inflamed mucosa or mucosa of the sinus that gets entrapped. Then they get larger and larger. So after some time they will burst by themselves. So they do not require treatment and they are a common finding. So as long as they're not doing anything to the cortications or you don't see any resorption or of that sort. So this one is due to inflammatory problems and it's causing elevation of the floor of maxillary sinus due to infection of the inflammation and infection associated with molar. And this one, we already know it. This is a dome-shaped mucosal thickening on the floor of the maxillary sinus. So this is again mucus retention pseudocyst, like the first one that we saw. So that's non-odontogenic. This one is odontogenic, and this one is non-odontogenic. So let's take a look at this one here. So remember we talked about mucus retention pseudocyst and we said it's basically it doesn't need treatment, and it's not a pathology really, but and we don't, and it basically doesn't need treatment. But in one instance, it may cause a problem, and that instance is when we have a larger mucous retention pseudocyst, and we want to put an implant and want to do a sinus lift. So in that case, we will have to basically elevate the floor of the maxillary sinus here, right? Remember, we would open a window here and elevate the floor of the sinus. So what happens if we push this upwards superiorly? Yes, it will go up and close the osteomeatal complex, and now we have created a problem which is sinusitis for the patient that before he did not have, and it will have adverse complications for our implant planning. So when there is a area of large mucosal thickening or a large mucous retention pseudocyst and you want to do an implant at that area, make sure that you consider this one. Send the patient to ENT to get treatment, or some clinicians, they make a small hole and then they suction the contents of the mucous retention cyst out, mucous retention pseudocyst out. So definitely something to consider. So this was a very nice case that we had for one of my female students that she graduated 2 years ago. So she came to me, showed me this PA, and she was like, Dr. Lavasani, I have a lot of pain, sinus pressure, heaviness in my right sinus, and this is my PA. What do you see? What should we do? I really am having a miserable night's sleep because I have postnasal drips. So taking a look at this PA, we all agree that this number 3 shows there is a elevation, localized elevation of floor of maxillary sinus. It may be a endodontic problem, and this number 2 has been endodontically treated. So let's take a, so we decided to take a CBCT because the modality of choice to evaluate maxillary sinuses is a CBCT. So take a look at the images that we saw when we took the CBCT. So you see that number 2 has a large endodontic lesion. Yes, okay. What else do we see? We also see the mesial root as we saw here, so we confirm it. But what we see that's so interesting is that the distal root has a periapical lesion, and that periapical lesion has caused interruption of the floor of the maxillary sinus. So basically now this area is a factory of infection, and it's kind of pouring its infection into the right maxillary sinus, as you can see, because sinus has to be filled with air on the left side, as you can see. But look at the total opacification of right maxillary sinus, and somewhere here is the osteomeatal complex that you see is totally opacified, and that's one of the signs of sinusitis. So no wonder that she was feeling heaviness and pain. So when I saw this, we decided to send her to ENT and get antibiotics, and also she had to do endo treatment for number 2 and 3. Otherwise, they would continue to produce infection in her maxillary sinus. So she went to spring break, and when she came back, she had significantly improved. So this is her CBCT after she came back from spring break and she had taken the antibiotics. So as you can see, there is significant reduction in the amount of infection. We have patent osteomeatal complex here very nicely, but you see there is still some infection that's remaining here, and that's the reason because these teeth are not yet re-endoed or like endodontically treated yet. So she still had to go to the endodontist to make sure that she takes care of these. Otherwise, again, in a few days, this would fill up and produce infection and opacification in maxillary sinus. So this maxillary sinusitis was due to odontogenic problems and due to the pathology associated with first and second maxillary molars. So this is a nice article about re-emphasizing what we just talked about. So they realized that of 135 sinusitis cases that they saw, most of them had odontogenic etiology. So teeth are mostly up to 70%, 60-some% responsible for causing sinusitis in our maxillary sinuses. And the most prevalent tooth that had infection and caused sinusitis in the maxillary sinuses was the first molar, and then followed by second molar. So here we have opacification of osteomeatal complex. Sometimes there is invasion or interruption of the sinus mucosa by an implant, and the sinus really reacts very severely. The whole sinus gets opacified, and sometimes I've seen cases that this happens and the sinus doesn't give any reaction. So it really depends on different individuals on how the sinus will react. We also can have different presentations of sinusitis problems. So looking at this right and left maxillary sinus, we see both of them are opacified. You see areas of bubbles, areas of multiple air bubbles, and I joke with my students, I say I think this person had a lot of champagne, but in reality this is a sign of bacterial sinusitis. Usually when people have bacterial sinusitis, bacteria produce air in that cavity. So these are all of those small airs from bacteria that conglomerate together and cause the appearance to be kind of bubbly shaped. So presence of air bubbles, bacterial sinusitis, and one of the signs that tells us that the patient has acute sinusitis can also be air fluid level. So you can see, you know, when you put a water in a glass, you see that it's kind of concave, or sometimes it can be irregular. This sinus shows that it has some areas of air bubbly and on the top of it. So this is called an air fluid level. Both of these can be associated with acute sinusitis. I want to bring your attention to one thing here. When the sinusitis is acute, still there hasn't been enough time to cause changes in the boundaries of the sinus. So you can see these sinuses are looking nice and very smooth. So the walls of the sinuses haven't changed that much. Well, in this one, this is thinner and this is a little bit thicker. So this may not be so new, but still, because of this, we can have acute symptoms. But what are the presentations of chronic sinusitis? Look at these axial views. So you can see this one is opacified, okay, but look at how smooth and nice are the boundaries of the sinus. So this one is probably acute sinusitis because the bone hasn't had enough time to react to the infection, trying to wall off the infection. While on this one, you can see that there's a lot of sclerotic kind of reactions happening. So this is so thick, the wall, medial wall, lateral wall, posterior wall of the sinuses are so thick and irregular. And that's because the bone is trying to produce a sclerotic material to wall off the infection so that the infection doesn't spread to our different parts of our kind of our face and skull. So what you also see here are areas of small calcifications. We call them dystrophic calcifications. Whenever there is long-standing infection, we have dead bacteria that get calcified, and there are kind of one of other presentations of a long-standing infection in an area of the body. So thickening and sclerosis of sinus walls and dystrophic calcifications are associated with chronic sinusitis. You can also see here again we have a dystrophic calcification. Again, there is thickening of the posterior border of the maxillary sinus. So also, we can evaluate the progression of sinusitis with CBCT. So here we had a failing implant here, so they decided to remove the implant. Before removing the implant, this was the situation. The patient already has sinusitis, but the sinus is not totally opacified. We have a little bit of bubbles, so that tells me probably it's a bacterial sinusitis. And then they took the implant out, so there is a large oroantral communication here. And sure enough, the sinus got even worse. So you see that there's no single area of air anymore, and there's total and complete opacification of maxillary sinus. And one of the reasons could be the passage of bacteria, oral bacteria, to the maxillary sinus. So definitely, if any of your patients have any sinus problems or sinus symptoms or nasal bleeding that's unexplained or any of those, definitely take a CBCT and send it to be read to see what's happening. So also we can evaluate sinus perforations. This was a failed implant, and I got this case to measure how much the bone has filled or has not filled after they took the implant out. So we can see that the measurement of the area is 7.2 on the coronal view, and this is the area that's 12.4 that now the oral surgeon has to go and kind of come up with a plan to be able to close this area. So definitely we can measure the area correctly and perfectly so that the surgeon has an idea to go and correct it. Also, you can see on this coronal view that there is deviation of the nasal septum. This is the nasal septum, and you see that it's deviated towards the right side. So these are all kind of small abnormalities that you can see. Sometimes they are so severe that they need intervention, and that's why pre-op they send them to come and take a CBCT when they want to do nose surgery. So let's take a look at the panoramic image in this one. So you can see the arrow is pointing at kind of a soft tissue blob that's coming down from the right maxillary sinus. If you look closer, you can see that we can't follow the floor of the right maxillary sinus in this panoramic image. What also we can't see is all the right side of maxillary sinus teeth that are gone. So that tells me that there's some soft tissue or malignant soft tissue, some problem that's originating from the sinus that's eating away the alveolar bone, the teeth that are involved, and it's kind of coming into the sinus. In another example, you can see that we have, let's say you take a CBCT, you want to put an implant in the right maxillary area, and you see there is sinus opacification. So basically all sinus opacifications are not created equal, because let's take a look. This one looks like a space occupying lesion that's eroding and resorbing structures in its way. So lateral wall of the nose is gone, middle meatus and turbinate are opacified and resorbed. This is area of ethmoids, and also you see superior elevation of floor of the nasal floor of the orbital cavity. So floor of the orbit is superiorly displaced. Usually it has to be something like this. So this tells me that this is an aggressive lesion. It's kind of resorbing and destroying everything in its path. So definitely this is not something that has to do with any simple sinusitis or something that's treatable or manageable in our scope of practice. So definitely this needs an ENT referral and medical CT with contrast, and then they can do MRI or whatever test that's needed. The job that we have is to, if we take the CBCT, to be able to differentiate if this is a problem or this is not a problem. So whenever you see a radio opacity, don't pass from it so easily. Try to see if it can be something else and something more destructive. Okay, so those were the pathologies associated with maxillary sinus. We can also have variations in vasculature. So we can have different branches of maxillary artery. One of them is this anterior superior or posterior superior alveolar arteries. So as you can see here, this is the posterior superior alveolar artery that kind of passes in the bone. Sometimes it can be just adjacent here, so doesn't have any imprint in the bone. Sometimes it can be inside the bone, and sometimes it can be within the lateral wall of the sinus, and sometimes towards the outside. So definitely if you want to do a lateral window elevation in the lateral window, make sure that you are looking for it to prevent huge amounts of bleeding. Similarly, we can have branches of anterior superior alveolar artery in the area of anterior maxilla. As you can see here, they are vertically positioned. So you can see here perfectly, you can visualize them in your CBCT scans. If you know they are there, you will look for them, and you can kind of change your plan or go beside them. If they are buccal, you go lingual. If they are lingual, you try to kind of change or be aware that they are there. So if you happen to kind of hit them, be able to manage the situation. So sometimes we can have variations of normal anatomy, meaning we can have septa within the maxillary sinus. By themselves, septa are not a problem, but whenever they are in the area of, again, sinus lift, you may want to know where they are, because at this area, due to presence of the septa, it's more difficult to elevate the Schneiderian membrane, and it may cause tears in your area of implant. So definitely you may come a little bit more distal, a little bit more mesial to avoid puncture of your connective tissue membrane. So those are the maxillary landmarks that we have to think about. Now we are looking at our mandibular area. So just like maxilla, we will have remodeling and we will have different shapes of edentulous alveolar ridge. Sometimes we can have atrophy as much as this one, that you can even see there is erosion of the superior aspect of the mandibular canal. So definitely there are different stages, different shapes of edentulous mandibular alveolar ridge. So one thing that's good for having cross section is that sometimes our bones look nice. Let's say how the height in this panoramic image reconstruction looks really nice. So but we don't have any cross sectional information. So do we have really from here to here all of it is usable bone for implants? Let's take a look here. So taking a cross sectional imaging, you see that, oh my god, there's so much thinness to the coronal aspect of this bone. So almost until here, or maybe even till here, this much of the bone, the coronal part of the bone, is useless to put implant. So the ridge is high, but the shape of it in the coronal part is not useful for us. So definitely gives us a good information of how much we have to shave the bone, how much bone we really have, and for us to choose the proper implant size. So also take a look at here. Do we have enough bone for an implant placement, or is there a problem here? The problem here is that the patient has a lot of basal bone instead of having alveolar bone. So the majority of his bone is below the mandibular canal. So again, that's a problem, and we have to manage it by reorienting our implants or changing the location. But it's important to know that not all bone are created equal. Some of them are useful to us, some of them not so much. So one of the things we can do with our CBCT softwares are localization of alveolar nerve canal. So here, this is a panoramic reconstruction. Let's say we draw our inferior alveolar nerve and we get our cross sections. So looking at these cross sections, the length of the bone doesn't look too bad, but look at the amount of undercut and abnormality, which is the area of submandibular gland. So this is a huge undercut and makes the height of our bone so short. So we have only, let's say, 8 millimeters, and if we kind of put a longer implant, we will be causing a perforation of the lingual cortical plate here, and that's a very bad position to be in. Here we have the sublingual fossa, and sublingual space, and sublingual space will get edema, bleeding, and then the tongue will go back, displaced kind of posteriorly, and there is a risk of choking, and the edema will cause the tongue to go back and close the airway. There are, I think, 13 cases that have been reported that patients went to do a simple implant, and similar situation happened, and they passed away in the doctor's chair. So definitely something to think about. Make sure that the patient has different variations of anatomy. Make sure your plan is failure proof kind of. So if it's like that, you can angle your implant in a way that you don't perforate the lingual cortical plates. So there are also different variations for inferior alveolar canals. So usually we have the mental foramen, which is now shown in red, but usually not usually, sometimes the nerve doesn't end there, so buccally it comes out, but you can also have anterior and superior extensions. This was a nice article that it was really showing how we can have basically incisor branch, and also you can the mental foramen can come out of any of these areas, and also you can have many vertical branches for anterior and superior extensions of the canal. Sometimes we can have bifid or trifid mandibular canal. So the main canal may be here, but in cross sections we see these areas that still contain nerve and arteries. So definitely make sure that we don't want to hit them and cause paresthesia and numbness and these problems for our patients. Other variations for mandibular canal that you can think about is retromolar canal. So retromolar canal is an area that kind of when from the mandibular fossa, the nerve enters our mandible very fast. You see there's at the end of the third molars, you see an area of nerve that is present. So if you want to go do extractions, if you want to do any type of surgery, it's nice to know that there is a canal that's containing nerve and arteries that we don't want to hit. So before there was a lot of research, they used to think that there are the interforamina or mental foramen to mental foramen in the anterior mandible was a safe zone. But soon when we had the cross-sectional imaging, we realized that there are not safe zones and there are many hemorrhagic incidents that are associated with implant placements in the anterior implant area. So as you can see, there are multiple anastomosing arteries and nerves that are passing through that area, and some of them lingual artery, they kind of have many branches that come out of here, and you can see all of these micro branches. So whenever you have anterior implants, definitely make sure you're looking for these small minor arteries because they can cause a lot of bleeding and again edema and problems with your patient's safety. This was a patient that had orthodontic surgery done, and I don't have the previous cross-sectional imaging, but now that she has these two screws in her anterior mandible, still she is feeling numbness and pain and kind of a weird paresthesia kind of a feeling, and I assume that there were some vasculature that here they were not paying attention to and kind of they hit them, so that thing is going to probably stay. So we don't want to be dentist that's going to be included in that kind of a scenario. One other thing we can learn from our CBCT cross sections is the quality of bone. Taking a look at this cross section, you see that we have a nice cortical bone, but looking at the spongy bone area, there really isn't that much bone density to tell us that there is any type of trabeculation here. Looking at this, I can kind of predict that when you open the case, there will be nothing. And in reality, there really was nothing. So it helps us to tell the patient and communicate and plan and tell them that we need to do bone grafts for you so that they are cost-wise and emotionally wise and surgery time-wise, we are prepared for that. So this is the graft area, and then you see we gained some density. This is kind of the trabecular bone density, and now the bone is ready to accept the new implants. So that's kind of the bone quality that you can expect from that to learn how the bone quality is. So this is a small kind of step-by-step guided surgery workflow that we have. So we can take the CBCT volume, we have the planning software, replica of the teeth and edentulous arch, we can do intraoral scanning, we can CBCT scan the dentures or different things. Whatever we do, we merge both scans, and then we can start our digital planning to see where the teeth are and where the bone is, how much bone we have, and so forth. And then we have different types of surgical guides, static and dynamic. Static is the more used one, dynamic is getting traction, and so forth. So basically short or like an abstract workflow of CBCT would be, you will have a panoramic reconstruction, you will get your basically all of these cross-sectional areas, you will draw your curve. When you draw the curve, you get the panoramic reconstruction, and then you draw your nerves, and then you drop your implants, and then you can kind of
move it buccally, lingually, superiorly, inferiorly, and make the proper shape and size of the restoration that you want to choose, and kind of shows you the overall overview of your digital workflow. For limitations, CBCTs have limitations like any other imaging modality. So CBCT artifacts, we have the most common ones: beam hardening, we have the ring artifact, cone beam effect, and motion artifact. So beam hardening is basically perfectly shown here, that you can see in the area of very dense objects we will have areas of darkness and black areas of beam hardening, and that's due to the polychromatic nature of our X-ray beam. So there are different energies. When they get to something dense, the low energy ones will stay and the rest of them will pass by, and the rest that pass by have higher mean energy. That's why they call them hardened, meaning they have higher energy, and when they have higher energy they won't react with any other tissue in their way, so they will go and straight get to the receptor. So let's say for implant planning, for implant imaging to see how is the bone implant interface, CBCT is not the modality of choice, and really PAs for the mesiodistal amount of integration are the best ones to show us how we have our bone, what's the bone level, and so forth. So different what we call selection criteria. So not always CBCT is the modality of choice, and sometimes we have to use our 2D images. Sometimes we can have motion artifacts. Whenever you see in your CBCT you have different lines, multiple lines that are here, multiple parallel lines, or here or different areas, you can see that your patient kind of has moved during the scan. So make sure that you really strap your patients down when you're taking a CBCT, because it really reduces the diagnostic yield of your scan. And then we have the ring artifact. When you see these rings in your scan, don't blame the assistant and call your people that you bought your CBCT from. Those people have to come and calibrate your machine. So this is machine calibration. And then we have image noise and poor soft tissue contrast. These are the two kind of characteristics that are associated with CBCT. Image noise, because of the way CBCT is taken, we have a cone shaped beam and it goes around one time, so there's a lot of Compton scattering that happens, and we have noise and poor soft tissue contrast, because look at the area. So we don't see, here's the area of the brain, but we don't see it.
Before I continue, I want to let everyone know that there will be a Q&A session at the end of our webinar, and I'll be happy to answer any questions you guys have. And you can ask your questions by from the dashboard, in your dashboard, from the drop down menu that you'll see in front of you. This was an interesting case that we had in 2016. This was a young 24-year-old patient that we had. You see that she had a well-defined radiolucent lesion that's corticated in the area of her left mandible. We were able to retrieve her dental records from the previous dentist. Apparently she had the lesion before, and the dentist saw it and he treated it by enucleating the lesion and sending the, let's say, specimen to pathology. So the pathology report was odontogenic keratocyst. So the dentist thought it's a simple cyst, and he has enucleated it, and he has done the job and completed the treatment. The reality is that odontogenic keratocyst is a very high recurring lesion, meaning it has a high recurrence rate. There are satellite cells, so the treatment has to be different other than just a simple enucleation. So that's the reason that this lesion got a recurrence, as you can see, and it's locally destructive. So for this turnaround we have to do a more aggressive, and probably some parts of her jaw may be removed, and also she may probably lose a number 18. So the moral of this story is that whenever you see something that has a significance, something that has, let's say, high recurrence rate, something that can make a difference, it's very nice to communicate with each other. I would think if there was a sentence that was put in this pathology report that this is an odontogenic keratocyst and it has high recurrence rate in the comments, so that would be something that possibly may have prevented this large lesion to return. So That concludes our lecture or webinar for tonight, and I want to thank all of you guys for paying attention. And these are my contacts here at this uh, slide, and let's start and get some questions from you guys. Thank you and have a good night.